Well, good afternoon, everybody. Thank you very much for joining us today. My name's Gemma Van Houten. I'm the Director of the Statistics Division in ESCAP, and it's my great pleasure to be bringing you this Stats Cafe today. In fact, we're just hosting it, and we're bringing four excellent speakers to you this afternoon on a topic which is very, very important always, but particularly important at the moment during the COVID-19. So this Stats Cafe series is just to give you MS Teams. If you haven't used the MS Teams tool before, in the middle, if you move your mouse to the middle of the screen, a black bar comes up, and it's there where you're able to put your camera on or off, mute your microphone on or off. Our speakers will be sharing their screens from there. And very importantly, on the right-hand side of the black bar, there is a function to raise your hand, and there is also a chat box. Now, today we've got four wonderful speakers from the World Health Organization, Australia and Sri Lanka. And we're going to slightly change our arrangement for Stats Cafes for those of you who joined us before. We're going to ask each of our speakers to speak very briefly, and then take questions, a couple of minutes of questions on each speaker. So I would encourage you, as you're listening to the speaker, please put the questions in the chat box. I'll then go to the chat box and invite questions for 2 or 3 minutes, and then we'll move to the next speaker. We've also allowed questions at the end, so don't worry if we don't answer your question in those couple of minutes. We'll pick them up at the end of the session. So it's my great pleasure to, first of all, introduce Mark Laundrie from the World Health Organization, based in Bangkok, who's going to share with us monitoring excess mortality due to COVID-19 and making sense of it for policymakers. Thank you very much. Over to you, Mark.
Great. Good afternoon. Thank you, Gemma, for this opportunity. So I was hoping I could just set the stage by just recognizing that COVID, like other diseases.
Sorry, Mark, could I just interrupt? Are you able to put your slides on full screen? We can't see them in full screen.
I think you're controlling it from your side.
All right.
Is this better?
No. I'm not sure what's happening there, Tanya. We're just sorry about that, Mark. We've lost them off the screen, Tanya. Now that's Sri Lanka's. Just try again. Tanya or David, are you trying to get them up again?
I think Tanya is.
Tanya is, okay. Try again. So
is it working now?
We just see PowerPoint so just press from the beginning. Yes, that's better. Thanks very much. Okay, sorry Mark, over to you.
Great, no worries. Yeah, I was just saying, as in any emerging transmissible disease, it's important that we know the epidemic, know our systems, and know our response. And this is a great opportunity to use this to improve the cause of death registration of death, as well as the cause of death information. Next slide, please. So when we talk about COVID-19 mortality, we have a really defined definition of this in a clear way, particularly recognizing that it could be both probable as well as confirmed test positive cases in a clinical context that is very clearly not associated with any alternative cause of death. Another attribute is the fact that these deaths cannot be attributed to any other disease, such as cancer or some other comorbidity specifically, but really is strictly due to COVID-19. And thirdly, that these are deaths that we are indeed counting as in our cause of death data collection. Next slide. So this is the cumulative confirmed cases as of yesterday. And you can see where I'm based in New Delhi in India, and actually where I'm from, the United States, still seeing massive increases in cases. But in large part, we've seen in most country contexts in the first 30 to 90 days, there was an increase in mortality and significant inclines. And we are seeing in a few instances, of course, a number of countries are gradually seeing their cumulative cases increase, such as Iran, for example, and in some places in Africa that aren't appearing specifically on this graph. Next slide, please. So this is an outstanding infographic from Virtual Capitalists. If you haven't seen this already, the link is there. Before we can maybe describe excess mortality, it is an interesting perspective to think about in a very back of the envelope kind of a crude way. What are people dying from on a daily basis? And so we can represent this in this way that we can acknowledge globally there's approximately 150,000 people that die each day. And these are what their causes are attributed to through burden of disease analysis. A third of those cardiovascular related, various other cancers and non-communicable diseases. We can see other types from communicable diseases and injuries. And you can see in the lower right where, in fact, if we took the average daily mortality for a number of different periods early on from early April, May, and that period, that it really has had a significant impact on the mortality on a day-to-day basis. But this isn't, really terribly analytical, but it is a quick and dirty way to consider the context of the COVID-19 mortality as a way to represent this on a daily basis of overall deaths globally. Next slide, please. So one of the questions that was asked in the registration was, how do we know and how do we really code and get our medical certificate of cause of death is accurate and of highest quality as possible? And here I'm referencing to the WHO guideline for medical certificate of cause of death. And you can see here a couple scenarios. In our standard certificate, we identify two parts, A and B. The first is the cause of death, where we look at the immediate cause and the underlying cause. And in the first example, this chain of events, we want to be able to document, in this example here, a test positive case of COVID-19 resulted in pneumonia, resulted in acute respiratory disease syndrome, and then understanding that this was indeed as a result of COVID-19. We also have to recognize that we may have suspected COVID-19 cases where we don't have a lab return result, but those are also valid and should be considered. But the other example is at the bottom, where we know through the transmission and nature of this disease that, in fact, we're acknowledging that there are cohorts of the population, particularly those that are older, that may have other comorbidities, and that these might have an influential factor or a significant contributing condition to perhaps the acceleration of the COVID-19 as it results into a chain of events. And so we often want to understand those relationships, and we can use the part 2 of the certificate to identify some of those significant conditions that may be contributing to death and log those in the example here as well under part 2. Next slide, please. So most of the countries in this Asia-Pacific region are using ICD, International Classification of Diseases, to code mortality and morbidity. Many are still using the ICD-10. There are codes available for this. And of course, we as WHO want to promote the use of this standard. And of course, those that may be already embracing ICD-11, there are codes available for that as well, for both test positive and suspected or probable cause of death associated with COVID. But of course, this is also, I think, an opportunity within the community to really promote better capacity building and cause of death determination and improving the quality of the data. Next slide, please. So what is excess mortality? So we're often asked this question, and put simply, it is just trying to understand over a certain period of time what is the excess or additional mortality that is occurring that would not be as detectable during a non-crisis mortality rate during that same period. And so when we're looking at this, particularly month to month over the last several months, it's important we can't look back to the previous month and or even consider maybe the same month just last year. But we do know that there is a pattern. And if we take the average number of deaths over, say, the last 3 to 5 years and compare that to the observed deaths for this current period, that's when we can justifiably and statistically look at and detect the observed deaths minus those average number of deaths to come up with that excess mortality figure. What we want to stress here is, of course, the importance of stratifying this data. And although we get a lot of data stratified by age already, often we're not getting the sex reported accurately or enough of the locational information, but there may be other attributes that might be valuable as well, such as ethnicity or socioeconomic factors as well. And again, I mean, the ICD becomes the common language for reporting and monitoring, and it's a way that we can consistently use and share this data as well as compare across countries in a very consistent way. Next slide, please. So just by way of introduction for the discussion today, I wanted to point out a few things of caution here. And we have to recognize that we are more likely to see and detect mortality due to COVID that's occurring in hospitals or health facilities. And we know that in most of the countries in this broader Asia-Pacific area, naturally there tends to be more cases of death or mortality occurring at home as opposed to in facilities. And so we have to recognize that up front. But we do tend to see more of the COVID-19 deaths occurring in facilities. There may be, in fact...
Excuse me, Mark, it's Gemma here. We just need about 1 more minute, please.
Sure. Yes, I'm sorry. So the other point here is that we do recognize there are a number of untested individuals that may be dying due to COVID. We have to acknowledge that the systems may not be sufficient to accurately detect this. And in fact, there are a number of results of increased deaths from other causes that might not be COVID related or associated with that. And then the converse is true. We're seeing a lot of fewer deaths in some cases, perhaps due to road traffic accidents because people aren't moving about so fast. Next slide, please. This is the last one here to point out a few points for consideration for policymakers. Sorry, next slide, please. So just a few, I'm sorry, go back, the key messages, thank you. Just a few points to recognize here that we need to know this disease and know the burden it's causing on our health systems. And this is a way to do this effectively with good quality cause of death information. It does indeed help us target interventions. It really is a way to improve the effectiveness and efficiency of both the emergency preparedness and response of this pandemic as well as other pandemics and epidemics in the future. And it helps us strengthen the resiliency of our health systems, identify and target those vulnerable and susceptible populations, as well as understand these patterns and trends. And I think the bottom line is this is also a lever to strengthen our civil registration and vital statistics systems. Thank you very much.
Thank you very much, Mark. Now open the floor to any questions that we might have. We've got about a minute for questions before our next speaker will come on. I have no questions in the chat box at the moment, but if anyone wanted to put their hand up and ask a question, I'm happy to go to you before we go to the next speaker.
Gemma, we also received questions before the session when participants registered, so maybe I can use those questions for Mark.
Sure. Just about a minute's worth though, Diane.
Okay, great. Yes, so one of the questions from a participant was how coding is done if the information found in the death certificate is probable COVID-19 and the person died before receiving the lab test results on COVID-19.
Yeah, so this would be a case where we would use the term suspected or probable cause associated with COVID-19, and then in fact, as necessary, could get a confirmed lab result post-mortem.
Thank you. And maybe just a second question. So how do you ensure the reported figures on COVID-19 by the different countries are comparable?
Well, I'll leave that question for Doris to respond at the end of this, but I think in general, we have to recognize that the data and statistics are as good as the quality of the data and systems that they're coming from. And so each country, we have to analyze and consider the constraints and issues around that. So it's really a country by country basis, but we do have a certain standard using the ICD, International Classification of Diseases, to report that in a consistent way. And we rely on that consistent quality and reporting by countries to do that properly.
Thank you.
Wonderful. Thank you very much. Thanks, Mark. And we'll come in. Doris may wish to raise that a bit later in the session as well. Now, I now have the pleasure to invite Australia, Lauren Moran from the Australian Bureau of Statistics, to talk to us about mortality reporting in the Australian situation and the changes that were required. Over to you, Lauren. Thank you.
Thanks, Gemma. I'll just make sure I'm sharing my screen.
Yes, we can see your slides.
Perfect.
And they're perfect. Thank you.
Excellent. So I'm just going to talk a little bit about some of the changes that the National Statistical Office has made in order to use CRVS data to help with the mortality monitoring effort during the pandemic. So I'm going to talk a little bit about the traditional model of mortality in Australia, some of the assessments around that, some of the changes to the processing, and just where we're headed in the future as well. So traditionally, we've had two main outputs of mortality data in Australia. So one is the data produced by the Australian Bureau of Statistics, and that's very much linked to the civil registration and vital statistics system. So we receive death certificates from the registries of births, deaths and marriages. We have 8 of those in Australia. We do a lot of demographic edits. We code them all to ICD-10 using IRIS, and we create this big annual output. And it's a very high quality epidemiological data set and very much used for foundational mortality statistics in Australia. And then we have the surveillance system, and the best known for the surveillance are our influenza and other infectious disease systems. So it's very rapid reporting, it quickly goes up to policymakers, but it can also be subject to change. So we know that lab tests can come in, things can differ there, and it's not always the information that lands on the death certificate. And really, in the past, these two have not had to come together. So at the start of the pandemic in Australia, the health departments and that surveillance system really took the lead looking at infections and mortality. We had a really low number of deaths. They updated data daily. It was all collated from our state and territory health departments, and every day they publish on their website, and that's our latest from yesterday. But as time went on, it was definitely realised that there were a few data gaps, because really the focus of this was COVID-19 only. So we started to look where we could perhaps provide some value add, and we had really 2 key objectives. So number one was around COVID-19 deaths themselves, and we really didn't want to create any confusion. So because there is a different number of deaths that we get registered due to certain causes, and the same will be for COVID-19, we were very apprehensive about producing a different figure from the surveillance unit around COVID-19 deaths. That could be really confusing for the Australian public. So that was one of our considerations. And the other one was around looking at policy questions not currently being answered. And the few that kept coming up were around excess mortality, effects of lockdown, effects of changes to health services. So we had cessation of elective surgeries for a while, delays in cancer screening, an uptake in telehealth, doctors talking to people online, and the questions were really coming up. Are these leading to increased mortality in Australia? And also things such as mental health, isolation, assaults, domestic violence, things like that. So we realised that we did definitely need to change our processes, that having such a complete and full data set, we were probably best placed to fill some of those gaps. We knew it had to have a population and a health perspective, but it could not take on that traditional format that the ABS would normally produce mortality data for. So normally we produce data about 9 months after a reference period, and that's a year, and that would mean that we wouldn't have any information until September 2021 for things around the pandemic, and we knew that would not really be okay. We also knew that we had to use existing CRVS systems and processes to innovate the outputs. So we had to get it up quickly, so there wasn't much time to change our processes, but we also couldn't burden our providers, and that's really the registries of births, deaths and marriages. They already had a lot of changes they were trying to take on themselves, and we were asking for quick change. So we started looking at what we had and came up with a new format. So traditionally, we always output by registration date. Because Australia had such a low number of deaths, we realised that we needed to change that to the date of occurrence of the death. So we could really look at that real-time change over years. So that was our first change. Our second big change was we had to remove all of our coroner certified deaths from the data set. And this is because of the legal processes involved in Australia, and it means we don't receive those deaths for quite a long period, and we would underreport anything we put out. So we're just reporting on doctor certified deaths. That does mean we don't have information on things such as suicides and assaults for the time being. We've also changed it so we're producing data every 4 weeks or 4 to 5 weeks. And really a big change for us is we're so used to having this reputation of producing this epidemiological data set. And things don't change. It's really the gold standard, but we've had to really change it to a provisional count. So things are a bit more subject to change. Everything is still coded to the ICD-10, run through IRIS, and that part is still gold standard, but we may get updates from registries as time goes on. And we had to simplify our methods for the moment. So we've used the excess mortality idea that Mark put up. So it's raw counts, it's averages. The baseline that we're comparing to is 2015 to 19. Currently, it's not stratified as we're working out the best stratification methods. So it is far more timely. It's looking at real-time change, and that cause of death is still coded through IRIS. Of course, we're still not sure if some of the registration patterns have affected the way we receive deaths. It doesn't look like it at this stage, but we have to be careful on that. And we still don't have information on the coroner referred deaths. And the other big thing is it's been a pretty big change getting used to producing data every 4 weeks rather than annually as well. So here's an example of the type of output we're putting out. So this is our latest one to yesterday, that we released yesterday. So you can see here that we have the current deaths are the red, so the dots mean provisional, and the purple are the actual COVID-19 infections, and we've added a range there. So we can see that there are some fluctuation in over years. And it does look like that during the start of the pandemics, when our infections were high, that we had some excess mortality. Whether that will change as we stratify the data is yet to be seen. And because Australia had low deaths, we decided to have an extra focus on causes of death to see if we could pin where some of these were. And so we can see that heart disease is actually fairly below, but diabetes and dementia are sitting above usual averages, as well as pneumonia during that time period. And pneumonia obviously has such a high interest due to its clear links to COVID-19. So the other thing we decided to look at was, could we value add around COVID-19 deaths themselves? And we didn't want to put out a new count, but instead what we decided to focus on was the cause of death itself and looking at associated causes. So we've started to look at causal pathways to deaths and existing comorbidities. So the causal pathways are really important because it is a new disease and we're learning more and more about it and how it does actually lead to fatalities all the time. So we can see in Australia here that pneumonia, respiratory failure, and we also have ARDS down there were some of the more common things. So it really followed that traditional respiratory pattern in the deaths we saw. And chronic diseases were also very commonly certified on death certificates with deaths due to COVID-19. So we'll continue to code those and update them, and we're exchanging information with our surveillance unit at the Department of Health to make sure everything's in line as well. So future opportunities. So we've had really positive feedback to changing our system, and we're going to continue working with the CRVS system agencies to see where we can further improve our outputs. So one of the big things will be around those coroner-referred deaths. It's a really important question, looking at mental health, looking at domestic violence, and whether things have changed during the pandemic. And at the moment, that's still a data gap in Australia. We're going to continue working closely with our registries of births, deaths and marriages. We really couldn't do this without them. And we'll look at when things move to digital environments. So the medical certificate of cause of death in many places in Australia is moving online, and whether that provides opportunity to really bring forward our production of mortality data once again. And of course, continuing to refine our statistical methods and take account of population changes, age, that type of thing. But this more timely release of data and starting to put our mortality data into the surveillance space in line with other agencies is something that we'll continue to do. So that was all I had really on the Australian situation. So happy to take questions.
Yeah, thank you very much, Lauren, and great timing there. David, questions from the floor, please. Over to you.
Yes, thank you, Lauren, for your presentation. So we got a few questions. The first one is, did you get mortality data in real time from a health institution? And how do you produce vital statistics with them?
Yeah, so we don't get it in real time. So we still have to receive the death registrations. So after 2 months, we have about 95% of our doctor certified deaths. So we're about 2 months behind our publishing. And that's also so we can completely ICD-10 code the data. But this is where we're hoping that the move to electronic systems will put us more in line with real time. But that's a starting conversation now with the registries.
Thank you very much. There was another question, but I think that one is more open, so I keep it for the end. And otherwise, before the session, we received a question. They were asking how effective is the process of registration of death during the COVID-19 pandemic?
So we've definitely been working with all of our registries to see what their thoughts are around registration during COVID-19, and it's been varied in Australia. I think especially where we've had higher infections, maybe they've had some more delays. One thing that's fairly interesting in Australia is we can't complete a registration of death until we receive the burial notice, and there were a few places in our very remote communities where burials had to be delayed, and in some of those places we had slight disruptions, but thankfully because they have low populations, it hasn't affected the overall registration rate, and it's still very high.
Thank you very much. I think we'll go to the next presentation now.
Thank you.
Wonderful. Thank you very much. Thanks, Lauren. Thanks, David. It's now my pleasure to invite Mr. Nandalal from Sri Lanka. Sorry, I won't be able to pronounce your surname correctly. And Mr. Nandalal is going to talk to us about Sri Lanka's experience with monitoring and reporting COVID-19 deaths. And I understand that he has some of his students phoning in today from Marshall Islands and Tuvalu. So good call out to you as well. Over to you, Mr. Nandalal. Thank you.
Thank you very much. Thank you very much for inviting me here to do this. So this is the Sri Lanka's experience in monitoring and reporting COVID-19 deaths. Actually, we are an island nation in the Southeast Asian region in very close proximity to India, with a land area of 65,000 square kilometers and a population of around 22 million. And our first reported case was on 26th of February, who was a foreign national, and the first reported local case was on 11th March 2020. As of today, the number of cases stands at 2,752 with 11 deaths, and our case fatality rate is 0.40%, which is really low. Thankfully. And we have 10 dedicated hospitals reserved for COVID-19 cases with ventilator facilities and 74 quarantine centers scattered all over the island. And nearly 50% of our cases are overseas returnees on mandatory quarantine. And we had 2 main clusters as of today. And the first one was at a Navy camp, where there were we identified 950 cases. But as of today, all are cured and there was no deaths and the cluster is closed. And we recently identified a cluster at a drug rehabilitation center where we have identified confirmed cases of 562, but the cluster is now controlled. And we don't have any community transmission as of now. So if you look at the epi curve, this is the epi curve as of yesterday, and you can see these 2 peaks. This is the Navy cluster, and this is the drug rehabilitation center cluster. And if you look at this is in the, if you visit the EPID unit, the website, you will see the latest. Then if you look at how deaths, including causes of death, are being monitored and reported during the COVID-19 pandemic, our routine reporting system existing in hospitals is continued. It is functioning as usual through the electronic morbidity and mortality return, and the data is sent to the medical statistics unit of the Ministry of Health, and the Ministry of the Medical Statistics Unit compiles data to produce annual health statistics for the Ministry of Health. So this is the routine system, but we have made some changes to the system to monitor and report on deaths and causes of death during the pandemic. All hospitals were given special instructions by way of a circular by the Ministry of Health Sri Lanka for mandatory notification of COVID-19 cases. Not only deaths, all the cases. So it declared COVID-19 as a notifiable condition, and every hospital must immediately inform cases or deaths to the epidemiological unit of Ministry of Health over the phone, and then followed by duly completed format via email to the epidemiological unit. And the epidemiological unit compiles the daily situation report, and it's something like this. This is as of yesterday. They give all sorts of data. So this is being updated every day at 10 a.m. If you look at COVID-19 fatality rate comparisons between the other countries and Sri Lanka, globally it is around 4.1%, and we are our fatality rate is just 0.4%. And if you visit this website, the Health Promotion Bureau, which is also a government institution, it gives you all the dashboards with regard to COVID-19. It's real-time data. It's updated every minute. And if you look at the recovery rates, the global recovery rate is around 60%, whereas our recovery rate is more than 75%. Then if you look at how the information on deaths and causes of death shared with the Civil Registration Authority and used for the production of vital statistics, we are using the WHO-approved international form of medical certificate of cause of death to certify deaths. The institutional death certification in Sri Lanka is carried out by our attending physicians or by forensic pathologists. They have already been given training in proper medical certification of cause of death, and additionally a rapid reference guide for correct certification of COVID-19 deaths, and a mobile app is prepared in collaboration with Vital Strategies. So when a death occurs, the attending physician fills the MCCD in triplicate. The first copy is given to the relatives. The second copy is sent to the local birth and death registrar, and the third copy is archived in the institution. So the local registrar sends it electronically to the district birth and death registrar's office, where the birth and death registrar officers from all districts send it to the medical statistic. It's a vital statistics units of the Registrar General's Department. The Vital Statistics Unit of the Registrar General's Department receives all MCCD from the entire country. At the VSU of the RG department, a set of mortality coders are there. They are trained in ICD-10 mortality coding, and they carry out mortality coding according to ICD-10, and which is done manually. And they tabulate the final underlying causes of death for the production of mortality statistics. And even the COVID deaths are going in the same way, except we have this special setup for which goes to the epidemiological unit, and they produce the real-time data, and this data coming out from the vital statistics unit, it's late. So, yeah, and thank you very much.
Wonderful. Thank you very much, Mr. Nandala. That was really very, very comprehensive, and I think it really showed how Sri Lanka was getting the information, very interesting in real time. Very pleased also to see such a small mortality rate there in Sri Lanka. We now have time for questions, and I'll hand back to David to manage the questions. Thanks, David.
Thank you, Jana, and thank you, Nandala, for your presentation. We also received a question. So there was, are the causes of death correctly being captured? So what is the percentage of ill-defined causes?
You mean in COVID or the whole?
I think in COVID specifically, but also in general.
Oh well, COVID. Yeah, the causes, there are no ill-defined causes with regard to these 11 deaths, because it is very, very specific. We know that it is definitely COVID. So all the doctors have certified that very correctly. But we do have ill-defined causes in other, like in day-to-day deaths. That's around 20%.
Okay, yes. Yeah, thank you. That's quite helpful to know. We also got another question now. So you mentioned 75% recovery. What could be the main factors for this high percentage of recovery?
Well, it's probably very, like there are more than one, I think there are more than one thing for this. Our people, they really listen to the the government and they use all the protective measures, probably the climate is helping also. And there is a, I'm not sure of this, but there is a saying that the BCG vaccination gives you some protection. Our BCG coverage is 100%. So these are more not proved, but they suspect these things.
Thank you very much. And finally, what is the percentage of death which have a medically certified cause of death recorded?
Come again?
What is the percentage? Yeah, in general, not only with COVID. Do all deaths have a medically certified cause of death that is recorded, or is it for just a small proportion of the death?
No, all deaths that occur in institutions are medically certified, but not the home deaths. So the home deaths, it's around 48%. So some of these are not medically certified.
Okay, thank you. And I just see another question now in the chat. Sorry, it's a lot of questions for you. How long usually does official vital statistics on death are released after the reference period, and how did COVID affect this, or did delay the release of official vital statistics?
Yes, we do have a delay of around 2 years. So we don't have the latest statistics for 2 years. So we now have the statistics in the year 2018. So that's a problem because we do the ICD-10 mortality coding manually. So there is a delay, but that's to overcome that only we have altered the flow by having an additional line for the medical the epidemiological unit. So they produce the real-time data.
Thank you. And I think we all still have another question. In Sri Lanka, which agency will produce the vital statistics?
Oh yeah, the Registrar General's department is the official department.
Okay. And well, questions keep coming in. Does the database only covers hospital death, not COVID cases that occur at home?
The Registrar General's department covers all deaths, not only the institutional deaths. There is another way of capturing the home deaths into the Registrar General's department database.
Thank you.
Yeah. And David, there's another question there from our colleagues in Samoa. Dr. Nandala, you mentioned 75% recovery. What could be the main factors for recovery?
Yeah, I think he already answered that question.
Ah, okay.
Thank you. Okay, thank you, Dr. Nandala, for answering all these questions. That was really helpful.
Thank you very much.
So I think we can go to the next presentation now.
Wonderful. Thank you very much. Thanks, David. Thanks, Mr. Nandala. And our final speaker today is Doris Marfat from the World Health Organization. And Doris is going to talk to us particularly around mortality, coding and COVID-19 and CRVS systems a bit more in general, but focusing on death registration. Thanks very much, Doris.
Yes,
and
good afternoon. Could you hear me?
Just very quietly, and your presentation's on the screen, but not in presentation mode.
I put it in presentation mode. Is that okay?
I think because it's got you need to enable editing so you can go into presentation mode.
Yes, okay, sorry.
It's okay.
Editing. Yeah. So, sorry, just give me a second.
Sure.
Now, can you see it?
Yes, and we're on the second slide, the one that tops cause of. Oh, it's still not in play. Just push play screen play. Screen share.
Just a second. Is that okay?
That's wonderful. And you are a bit quiet, so just maybe speak a bit close to the microphone. Yeah.
Okay. So as Mark, my colleague, mentioned, the importance of having a good CRVS system to monitor mortality data from COVID-19. As you know, several global partners in the UN, including ESCAP, we promote CRVS system for proper recording of vital statistics. And the pandemic has actually highlighted the critical need of accelerating efforts towards building countries' strong CRVS systems. Why do we count deaths? We count deaths to save future lives.
Excuse me, Doris, sorry to interrupt. We've lost your screen for some reason.
It's still sharing now.
Yes, now it's sharing. Yes, thank you.
Okay, sorry, maybe I should be slower.
No, that's good.
Okay, we said, why do we need to count deaths? We need to count deaths to save future lives. Every death should be counted. Every death should be registered, and ideally with its cause. And this is mainly because if we know why people die from, we can develop health prevention programs to save future lives. And counting within an integrated system, that is ensuring every death everywhere in the country is recorded. Deaths in prisons, detention camps, in health facilities at home, and if your resident is traveling abroad as a tourist, it should also be captured back in your vital statistics. And avoiding double counting of deaths, that is somebody dying of COVID-19 and also somebody dying of COVID-19 and also have other diseases like heart failure or heart diseases, should only be counting once, not as two deaths. And all these deaths should be then compiled in one place for consistency. So CRVS system is composed of two systems. Civil registration, which is a continuous, permanent, compulsory, and universal recording of the vital events. Its purpose is for the law, and cause of death reporting is ideally linked to cause of death notification and registration process. The vital statistics system comprises of all these different elements. It consists also of live births, birth deaths, fatal deaths. And that's then part of this registration system, including population registers, that produce vital statistics. The literature sets the global standards to enhance the comparability of mortality data. As we mentioned before, the ICD with its new codes for COVID-19, then the cause of death should be noted, certified on the International Form of Medical Certificate of Cause of Death. Then you have ICD rules to select and modify the underlying cause of death. As Mark mentioned, some examples. And you have standard definitions of what is maternal death or fetal death, and of course standard reporting requirements in terms of age group and cause risk. The vital registration data is very important. One of them is for monitoring trends in causes of death. This is an example of lung cancer deaths. Sorry, I didn't show here. It's trends in lung cancer deaths. And for countries with good CRVS system, it actually shows how lung cancer mortality is going down due to anti-smoking campaign or taxes on tobacco. Reducing vital registration cause of death statistics is a multi-sectoral responsibility. This is an example where it's a death due to a road traffic accident, where it involves the medical sector, the doctors in the hospitals, the police sometimes, there's an investigation comes from it could be part of the Ministry of Justice, And then all this information have registration in the civil registration office, and these data are then shared with the National Statistics Agency. So without a government commitment on these multi-sectors, it's not possible to have what we call a functional CRV system that is producing all these macro statistics. So it's a real engagement from the government to involve all these sectors. And once the information on these macro statistics, including causes of death, are captured, they're normally shared with other institutions. For example, deaths will be somebody died, he has to be removed from the electoral register, or his pension will be stopped, or be used to give a social allowance to the widow or widowers, the orphans. And also, national ID should be informed of somebody dying so that they know this person, this national ID, its ID number should no longer be used for official purposes. And without VR data, it's a real global challenge for estimating what people died from. So the data which countries compile and send to WHO use them to produce very interesting report, on deaths in the world, like on road safety, drowning, how many people died from, how many people died from TB, maternal mortality. So without good VR data, it's a real challenge, and then what we rely on will be on modeling purposes, which has a large range of uncertainties. So it's really, the pandemic has highlighted the need to have a good CRV system that will allow you in the long term to monitor all your causes of death, including those during pandemics. That's what I have to say. Thank you very much.
Wonderful. Thank you very much, Doris. And we really do echo the message from the World Health Organization about the importance of registering all deaths so we get a good understanding of what's going on. David, back over to you for questions, please.
Yes, thank you, Fiona, and thank you, Doris, for your presentation. So I think the first question would be from Niall. How can one deal with the reluctance of a family to report a death that is COVID-related as COVID, sometimes for fear of stigma or isolation?
Sorry, is that a question to me?
Yes, to you, or maybe to Mark, or to any other panelists.
So what was the question, please? Can you repeat?
How can one deal with the reluctance of a family to report a death that is COVID-related as COVID, sometimes for fear of stigma or isolation?
I don't think it's a personal decision, when you're fearing stigmatization. It's the system in your country, if the medical doctors are trained to report the cause of death as they are diagnosed, and it should be reported in the medical certificate of cause of death. Now, is that information shared with the family or not? Depending on system. In some system, the information is kept secretly, and in some system, we share the information. But definitely, when we publish data, it is very important to anonymize, so that people don't know, people don't start pointing out that somebody died at province or this, at the age group. So it's important when publishing vital statistics that this consideration are being taken. That is, either you group the age groups, if you have only one death and you group them, or you show only all ages, and that this detailed information are kept, in a confidential database. I think this is, the system has to take that into consideration so that to alleviate the fear of the family too. Thank you.
Yeah, thank you, Doris, for that point.
And David, just to add to that, I think just like we've seen with leprosy or HIV/AIDS, I mean, it really does take a lot of community awareness and advocacy and campaigning just to change the culture and understanding of these diseases. And I think that also really is needed. It takes both a scientific approach, but also working with communities and civil society.
Yes, thank you. I'll follow up with a question for the two WHO panelists. So referring to the point that countries largely report COVID death occurring in hospitals, resulting in underreporting. So in normal years, for example, in India, only 22% of death get reported, while 48% of death occur at home in Sri Lanka and may be underreported. Using the excess mortality estimations, can we define the level of underreporting for COVID death? I don't know, Doris or Mark.
Okay, I may tackle this question. So, in fact, we don't need, let's say don't need. We can measure the excess mortality in an indirect way by tackling the total number of deaths in your country, knowing how many people died, because that number of deaths, you should be getting it, in the registration office. And so if you have this total number of deaths, even if you don't have a cause, you should be able to measure the excess mortality. And then you can model the excess mortality, what is the proportion that is caused due to COVID-19, given the prevalence of the cases of COVID we have from the surveillance systems. So another way is to do what we call a rapid mortality surveillance system to capture only the total number of deaths, because I know that in many countries you may not have doctors available to certify the deaths in rural areas. So having the total number of deaths, even by very small area, at the local district level, would help to monitor any excess in the total number, and maybe then bring your attention on policy that there's something happening there.
Can I add to that, David? In Sri Lanka, definitely we are up to now, we have not missed a single COVID-19 deaths because we don't have community transmission. So we are sure that there are no deaths in the community because we do random PCR testings in the community also. We up to now, all the PCR tests have become zero. So for sure, we don't have COVID deaths unreported up to now, but definitely yes, for other causes there can be. Yes.
Okay, yes. Thank you. And related a bit to that question on excess mortality, is there a preferred definition of expected death? Is the average of the past 5 years ideal? That could be for Doris or any of the other panelists. Doris, you're muted.
It depends how good were your previous years of data. This is very important. If your previous years of data are complete, then you can safely use them. But if they are incomplete, then you have to do an adjustment for the incompleteness before you start comparing. Or you can use other sources of information. It could be from the past census, that you have, recent census, and try to extrapolate from them. Thank you.
Thank you very much. And I think we'll finish with the last question. So that's directed to all panelists. Should the future of CRVS system lie in a close relationship with surveillance systems to permit rapid assessment of excess mortality by age and sex weekly on a continuous basis, combined with a slower, more deliberative process to code and analyze medical causes of death?
Yes, definitely, I would say, because I mentioned the CRVS system is a complex system engaging many sectors, including the health sector. So the surveillance system is part of the health sector, and it should be linked, in fact. And the better it's linked, the better information would go much more faster to the registry and also to the statistical office.
Yes, I would second that too. I think it's you can learn from each other, and both have so much value to offer in the space.
Absolutely agree.
Yeah. And Mr. Nandala, last word to you, Mr. Nandala. Or you're on mute, sorry.
Can I just answer that question again about the high recovery rate? the first thing is every case of COVID in Sri Lanka is hospitalized and treated by the doctors, and all the supportive care is given for all the cases since our numbers are low. And the public is adhering to the very the good health practices, and some of these are enforced strictly in the community, and they suspect the BCG vaccination has some effect, but this is not proven. But our BCG vaccination is 100%. And then they also suspect the climate, the temperate climate here, the warm climate here is also helping. So those are the 4 main things that has this the reasons for this high recovery rate.
Wonderful. Thank you very much. Thanks, Mr. Lam. I'd like to actually thank all of our speakers today and the team who've put together this session. It's been a really interesting, extremely specific on the issue of death and mortality and death coding, but extremely relevant and topical at this very unfortunate time we're all in with COVID-19. So on behalf of ESCAP and all of the audience here today, I'd like to thank Mark Laundrie from the World Health Organization and his colleague Doris Marfat, who's calling in very early from Geneva there. Lauren Moran from the Australian Bureau of Statistics and Nandalal from Sri Lanka for sharing with us the World Health Organization as well as country perspectives on this topic of death recording. The session was recorded, and we will have the recording of the session plus the slides and links to various documents that have been prepared on this topic available on our website, and we'll share them with you after today's session. And I'd also just like to highlight that next week we're changing onto a very different topic, which is called mapping land cover change using GIS and remote sensing. I know we have a very active community out there in Asia-Pacific interested in GIS, and our colleagues from ESCAP and from Thailand will be sharing with us mapping land cover change next Wednesday, the 29th of July at 11 o'clock. We'll be sending an invitation out to you all, but I just wanted to put in a little bit of an advertisement for that here. So thank you again. I really do appreciate taking the time here today, and to the organisers. It's been really very interesting, and we look forward to seeing you all again at the next Stats Cafe next week. And thank you for your time. Have a lovely day. Thank you.
Thank you.
Thank you.
Thank you.